welcome to Global Healthcast, brought to you by Global Health Press. We have a special today on dengue. And as many of you will not know what dengue is, I have invited a great expert, an old friend of mine for more than a decade, Professor Marco Sáfadi from Sao Paulo in Brazil. Marco, a very warm welcome to this dengue special here at Global Healthcast. Good morning.
Good morning, Joe. It's a great pleasure to be here, and I'm very happy to share some data with a disease that is of really major public health concern in several regions in the world. So let's start.
Yeah, actually, the first question then certainly would be, what is the risk of dengue, right? I'm sitting here in Europe, I have fun, I don't even know dengue, right? If I wouldn't know you, I wouldn't know dengue, I guess.
Yeah.
Anyway, what's the risk of dengue?
I will present a picture that is very illustrative and shows what the risk of dengue around the world. Currently, Joe, we estimate to have approximately 4 billion people at risk of infection with dengue viruses. 70% of these population at risk is in Asia, but we have a huge risk of dengue in the Americas. Dengue causes the greatest human disease burden of any arbovirus. We estimate approximately 10,000 deaths every year and approximately 100 million symptomatic infections in over 125 countries. And I can say that, unfortunately, one of the leading countries in the last decade of dengue reporting cases is my country, Brazil. So actually, this is a disease of major public health concern. In terms of Europe, just to illustrate the picture, although the number of cases reported in Europe is very, very limited, it's important to know that you have in Europe the presence of the vector, which is the Aedes mosquito. So theoretically, you can have dengue cases even in Europe.
This is interesting. I am aware of this, as you can imagine, as an infectious diseases person. And as I see this mosquito here on your slide, I guess the next message would be it is transmitted by a fly, right? By a mosquito. And what can you tell us about the endemicity of the types of transmission of the virus to humans in various countries?
Well, Joe, the main vector transmitting dengue is the Aedes mosquito, Aedes albopictus, and Aedes aegypti. Aedes aegypti is obviously the most important vector transmitting dengue. And once you have the presence of these vectors, theoretically, you have the risk of acquiring dengue once the virus is present in your place. We are seeing an increasing number of cases reported around the world, an increasing number of countries reporting dengue, and also travelers. We are seeing an increasing number of travelers that goes to the Americas, that goes to Asia, etc., acquiring dengue when they return to their places.
That is interesting. And if I look at this slide, what I see is that most infection, it appears to me, most of the cases that are reported are young people under the age of 20 years, if I see this correctly. I'm living in Europe. I would expect that in Europe, dengue may have a different age preference, right? Young people don't get it, they are not immune, and then it's probably more everybody can get it. What do you think?
No, this slide, Joe, actually is to show what happened in endemic countries. So the idea of this slide is just to highlight that in endemic countries, and here we have Asian and American countries, showing that, for instance, if you pick here India, Indonesia, Malaysia, Vietnam, Brazil, Thailand, and Puerto Rico, we see that for instance, at 9 years of age, approximately 50% of these young people have already been infected with dengue, to show that the prevalence of the infection is extremely high in those endemic countries. Obviously, if you do the same kind of seroprevalence study in Europe, you will see almost nothing. Probably the seroprevalence of the population in Europe will be close to zero. So this is not an infection that is prevalent in Europe or endemic in Europe. This is to show how important it is and how high the seroprevalence is even in young age groups in those endemic countries.
Okay, thanks for clarifying this. Now, my next question would be, is there is not only dengue, there are other arboviruses. And actually here in Europe, we do have tick-borne encephalitis all over Europe and Asia. So the question then is, what is this in the America region? I know that you mentioned already it is 4 billion people, which means half of the world's population are at risk for dengue. So how important in this respect is dengue in the Americas?
Yeah, you touched in an important message, but it is not. Dengue is not the only arboviral infection that poses risk to our population. It's the most important currently, but we have other arboviral infections also of major public health concern. And we had the Zika, you remember, years ago. We have a huge outbreak starting in Brazil with the identification of those cases of severe congenital infection. Actually, Brazil was responsible for reporting to the world the possibility of this infection once acquired during pregnancy, resulting in the risk of very, very severe congenital malformations. And we also have another arboviral, which is of key relevance, Joe, which is chikungunya. Actually, chikungunya, for me, together with dengue, are the two most important arbovirus currently in our region. We can discuss in another program the issue of chikungunya, but chikungunya, most of the persons who are infected become symptomatic, and the symptoms may last several weeks or even months after the person is infected. So a major public health concern, and unfortunately, we are seeing increasing numbers not only of dengue, but also of chikungunya in our region.
Very interesting. And I remember there are chikungunya cases now in Europe, in Italy, I remember. The bad news is there will be more of what we made to speak about at a later point, right? But let's say with dengue, and so this is really important from the case numbers that I see here. And your next slide already is on the flavivirus dengue. So that's a flavivirus, right?
Yeah, this slide is just to highlight that this is a flavivirus, the same way as the yellow fever, the same way as Zika, the same way as West Nile virus and several others. So dengue belongs to the Flaviviridae family. And very important, Joe, there are 4 different serotypes: serotype 1, serotype 2, serotype 3, and serotype 4. It means that you can be infected 4 times in your life once these 4 serotypes are antigenically distinct. The idea of this slide is to show that we have structural and non-structural proteins, and all these proteins, they have a key role in terms of immune pathogenesis, of inducing protection, etc. So we may discuss this later, but the idea here is to show that this is a flavivirus with 4 different serotypes.
Now, the question then would be, if you can get infected 4 times, what is the reservoir? Where do I find the dengue virus?
Yeah, as I previously mentioned, Aedes aegypti and Aedes albopictus are the 2 main vectors of dengue, particularly Aedes aegypti, which is the most competent vector of dengue virus. So these two mosquito vectors are described as highly competent in the transmission of several arboviral infections, including dengue.
So the reservoir is the mosquito. And
the vector is the mosquito.
The vector. And the reservoir is humans, if I look to the left side of the slide, right?
Yeah, you have the intrinsic and the extrinsic cycle of the virus.
Okay, so infected humans who are viremic get bitten or get stinged, whatever you call it, by a mosquito. The mosquito sucks blood and picks up the virus and brings it to the next human being. Is that it?
That's exactly what happens. And just to highlight that the mosquito that is responsible for the transmission is the female mosquito.
Oh, okay. Very good. No, not very good, but very interesting. And that is something we can also discuss later on. So the mosquito harbors the virus. It is infecting itself by viremic humans, and then other humans are infected. And now once the virus is in the blood, there is what I see already on the next slide, a quite complex immune response, right?
Yeah, the idea of this slide is just to show that not all the persons that are infected with dengue acquire a severe dengue infection, but there are some situations where a severe presentation may occur. This is multifactorial. So we also have identified more virulent genetic strains, some genetic variations of some of the serotypes. We also have identified some comorbidities that play an important role, increasing the risk of developing severe dengue, like asthma, diabetes, some sickle cell disease, the presence of some HLA markers, some gender age issues. Currently, most of the death reported here in Brazil associated with dengue, Joe, are reported in elderly. So elderly, due obviously to the fact of having comorbidities, etc., are the age group where we are currently seeing the highest proportion of death associated with dengue. But the main message here is the following, Joe. Let's say that Joe Schmitt visit Sao Paulo or some region in Brazil and get infected with dengue. So probably will be your primary infection, and you are theoretically infected with serotype 1. It means that you will develop immunity against serotype 1. It will last theoretically to the rest of your life. You will be protected against dengue serotype 1. And immediately after being infected, you also acquire a very limited in terms of time immunity to the remaining serotypes, 2, 3, and 4. But this protection lasts usually a few months, and after few months, you are susceptible to serotype 2, serotype 3, and serotype 4. And paradoxically, Joe, once you are infected again, and let's say that you then visit Thailand, and in Thailand, years after being infected with serotype 1 in Brazil, you are infected with serotype 2. Then we create theoretically the situation of potentially severe presentation of dengue. So this is a secondary infection. We have time interval, usually over 1 to 2 years. And paradoxically, instead of being protected, once you are infected with another serotype, the presence of antibodies that you had, which was neutralizing antibodies against serotype 1, but these are non-neutralizing antibodies to the other serotype. So instead of protecting you, these non-neutralizing antibodies actually will increase the probability of developing severe dengue. It's like an antibody-dependent enhancement phenomenon triggering acute phase proteins, cytokines, formation of immune complexes, and resulting in increased capillary permeability, loss of coagulation proteins, and then you have a situation that may result in a severe presentation of dengue. So it's very intriguing, Joe, because maybe this is the only infection that once you have one infection with a determinate serotype, you have now a situation that increases the risk of having a severe presentation once you are infected with another serotype.
So if I understand this right, the dengue virus serotypes are not really that close related to each other. It is not like serogroups. It is really no good cross protection. And
Exactly.
once you're infected with one, you are protected against this one serotype for life. But as antibodies go down and become less, with a second infection, you get more severe disease due to to some persisting antibodies that do not kill the virus, but that may enhance inflammation. And that is why you have more severe disease. Is that correct?
That's correct. So actually, these antibodies that you acquire in the first infection are neutralizing for the serotype that infected you, but they are non-neutralizing antibodies to the remaining serotype. And that is exactly what happened. But there is another very intriguing message, Joe, that the risk of severe dengue is really associated with the secondary infection. This is a very interesting study that was done on a cohort of individuals and followed over 5 years of age for at least 5 years. And what these studies showed, something that we already knew, is that the risk of severe dengue is really close associated with the secondary infection. So the third and fourth infection, they are usually not associated with severe dengue. So for some reason, once you have a secondary infection, it results in a kind of immunity that will actually protect you, even against serotypes that are naive to your organism. So it means that the risk of severe dengue is really associated with the secondary infection.
Interesting again. So this reminds me of vaccine serology. If you give one dose, you get a nice immune response. If you give 2 doses, the immune response is broader. And the more you give, and particularly with a booster, you get the broadest, a very broad coverage of related antigens. So it looks a little bit like dengue 1 is not giving you a broad response, but dengue infection 2, 3, and more may give you a very broad response, and you're really much better protected than with one dose, with one infection only. Is that the right comparison?
I think, Joe, that the message here regarding vaccines is that for a vaccine to be really effective and not associated with the risk of a secondary severe dengue once this person is infected after being vaccinated, is that the vaccine has to result in a very balanced response against the 4 serotypes. So this is a key message when developing dengue vaccines. Dengue vaccines should induce a robust and balanced immune response against the 4 serotypes, not to induce a risk of severe dengue for those persons that are vaccinated once they are infected later with a determined serotype.
Yeah, I understand that. Yeah. Now, what is next on your outline here? What's the next message?
Yeah, this is a slide that I think is very didactic, showing that very interestingly what I shared with you, Joe, in terms of the risk of severe dengue. See this picture. These are a study that was done associating the risk of developing those severe outcomes. You see here dengue hemorrhagic and dengue shock syndrome and hospitalization due to dengue according to the level of antibodies that those subjects had. So we see that once you have a high level of antibodies is exactly the situation where the risk of developing those severe outcomes is really, really, really low, as you see here in blue. And actually the risk of severe dengue disease will be highest within a narrow range of pre-existing anti-dengue titers. So we see here in the picture in red, we see here at this narrow range is exactly the narrow range where we see the increased risk of developing those severe outcomes.
Okay, so yeah, this is nicely correlating antibody titers with disease severity, and the point is the more antibodies you have, the higher is your risk for severe disease, which is contra-intuitive, right? This is not what you expect, right?
No, actually, Joe, the higher the level of antibodies, the lower will be the risk of developing the severe outcomes. The risk is really associated with a narrow range of pre-existing antibodies, which is non-neutralizing antibodies that instead of protecting you, they will induce actually a higher risk of this severe presentation once you are reinfected.
Thanks for clarifying. This I didn't get, and thanks for clarifying again. So it is the red bars,
exactly,
which is not so high titers even that put you at risk.
Exactly.
Yeah,
that's exactly the point.
I got it. Thank you very much.
This is just clinical presentation of dengue, just to highlight that we estimate that 1 in each 4 persons that are infected will result in a symptomatic infection. So the disease is recognized in 1 in each 4 persons that are infected. So when I say that we have approximately 100 million cases per year, these are 100 million cases of symptomatic infection. It means that we have probably 4 times more persons that are actually infected with dengue. The symptomatic infection most commonly presents as a mild to moderate infection, non-specific acute febrile illness. Dengue has a very wide range of clinical presentations, since asymptomatic infection, as I highlighted, to classic dengue fever and even severe dengue. We estimate approximately 1 in each 20 patients with dengue virus disease that will progress to develop the severe life-threatening disease called severe dengue. Early clinical findings are actually non-specific, requiring a high index of suspicion. It means that the early symptoms of dengue, the early signs of dengue, is really common to several other viral infections like influenza, like COVID-19, like several other infections that we may be a confounding factor to really identify dengue. The last bullet is one of the most important messages regarding this slide. And this is something that we are using. It means in places where dengue is a major public health concern. the importance, Joe, of recognizing early signs of shock. Persons that die due to dengue usually die because of the shock that dengue induces. So the key message here to clinicians is really to be very alert to identify early signs of shock. If you identify those early signs of shock and really start with this supportive therapy, etc., you will reduce significantly the risk of those patients dying.
Marco, one question. You have these two slides, two pictures of rashes. Are they with the mild disease or are they with the severe disease? I mean, that should be the mild disease, right? Or maybe the child on the right side, there may be a bleeding in the skin.
No, I think your question is very important, Joe, and it's a nice introduction to the next slide that we see here. So this is the disease course of severe dengue. So that rush that I showed in the previous slide, this non-specific rush, is something that we see frequently with dengue. So we have this initial phase, which we call febrile phase. So classically, dengue will be characterized by this non-specific acute febrile illness, usually lasting less than a week and accompanied by headache, malaise, retroorbital pain, sometimes arthralgia, sometimes myalgia, nausea, vomiting, and usually at the end of this week, usually after 4 to 5 days, we see this maculopapular rush. At this time, Joe, most patients will improve and the fever usually go down, and that's the end of the clinical symptoms. Usually most patients will recover. However, at this point, after the patient's fever is starting to subside, some patients, fortunately not all, but a minority, will progress to the critical phase of dengue, where dengue becomes life-threatening very quickly due to the plasma leakage, fluid accumulation, respiratory distress, and sometimes severe bleeding or severe organ damage. This is what we call the critical phase. Unfortunately, most of the patients after the initial febrile phase, they recover. So, but you have to be very alert when the fever starts to subside, because this is the way that some patients will recover and some patients will progress to this critical phase.
Okay, so the rash, from what I see in here, is like many other viral rashes, antibody-mediated, right? It is sort of a vasculitis in the skin, and you see the vesicles are enlarging, and you see the redness. And I trust upon pressure, the rash will disappear, right?
Exactly, Joe. That's clearly exactly what happened.
So this is then, if that comes, it's done, right? If you have that rash, you have antibody, you have immunity, and that may be the story if it was the first infection.
Exactly. So it is what happened, and usually if the patient don't progress to the critical phase, the patient will recover in few days.
Okay.
This is this slide with the new classification of dengue, showing probable dengue, which is a kind of reporting the presence of fever, rush, etc. Usually you have leukopenia and the warning signs. This is very important to clinician, and I will touch it in the next slide to highlight what are the clinical signs that once present may represent a risk of progressing to severe dengue. And the severe, actually the criteria to define severe dengue, which is the presence of severe plasma leakage signs, severe hemorrhage, and severe organ damage. So here, Joe, I highlighted what we call signs, alert signs or warning signs. It means that if you have a patient with dengue who presents at least one of these warning signs, it means that these patients may progress to severe disease. And once these signs are present, we usually recommend that this patient be hospitalized and treated in the hospital. So severe and continuous abdominal pain, persistent vomiting, signs of clinical fluid accumulation, mucosal bleeding, lethargy or restlessness. So sometimes the patients have irritability alternated with lethargy. If you identified liver enlargement higher than 2 centimeters, and lab finding of increasing hematocrit concurrent with rapid decrease in platelet counts. So if you have a patient, Joe, with one of these warning signs, it means be alert, hospitalize this patient, start with the hydration, etc., which is very important to decrease the risk of progressing to death. And usually these warning signs occur in the end of this of that initial acute phase that I mentioned in the previous slide.
I certainly, I guess this is definitely true for your country. I just wonder, in my former hospital, if a patient would have come with any of these signs, I would have thought of anything but dengue. So the lesson learned for me today is we should tell physicians in Europe that they should know about this. The disease may well be around, and it may, number one, be in travelers, but it may also become endemic with time, and we may have, with global warming, endemic dengue in Europe.
That's it. That's correct, Joe. We are currently discussing that climate change, etc., are situations that are increasing the number of countries reporting dengue and increasing the risk of dengue.
Yeah. So what is severe dengue? Well, here you have it. Yeah.
Yeah, just to show, as I mentioned, we call severe dengue when we have signs of severe plasma leakage, signs of severe hemorrhage, and signs of organ damage. So usually when the patient reaches these severe presentations is usually the situations where the risk of death is present. And as I mentioned previously, it's very important to prevent shock and to treat shock very vigorously with IV hydration, etc., to really prevent these hypovolemic shock that we usually identify in patients with dengue.
Marco, what do I see on the ultrasound images that were on the top? I think one was abdomen, but I'm not sure.
Sorry, I didn't get your question, Joe.
What do I see on the ultrasound pictures on the top line?
Okay, these are signs of severe plasma leakage, both in here we have pleural fluid accumulation and abdominal fluid accumulation. So ascites, pleural effusion, etc., which are clinical signs that we see in those patients with severe plasma leakage.
Thank you. Thank you. All right.
And this is the lab change, Joe. I think the message here, and we see a lot of mistakes for persons trying to confirm the diagnosis of dengue. So the key message here is really to remind the physicians which lab test to ask depending on the timing of the presentation of the patient with suspicion of dengue. So it means, if you see here, this is a very busy slide, but just to highlight, let's see, for instance, the presence of antibodies, IgG and IgM. You see here IgM in gray, and you see IgG in blue. And the febrile acute phase, so day 0, day 1, day 2. Let's imagine, Joe, that you have a patient that returns from Brazil and starts in Frankfurt of having a fever, headache, and he has a macular papular rush. You have 3 days of symptoms. Which lab test would you ask for this patient if you have a suspicion of dengue? So if you ask serology, IgG and IgM, and we are in the 3rd day of symptoms, see that in the 3rd day of symptoms, it's very unlikely to identify the IgM antibody. So we currently see the presence of IgM antibodies not before the day 5 of symptoms. So if you suspect of dengue and you have a patient with less than 5 days of symptoms, the lab test that you should ask is the NS1. So NS1 is usually present very early, with less than 3 to 4 days of symptoms, and obviously the PCR if you have it available. Only ask for serology if your patient has at least 5 days of symptoms. Is it clear, Joe?
Yeah, it is clear. The issue is more, where would I get here in my area an NS1 serology for dengue virus? I guess it would be the history of the patient, and if I look at your slide, the decreasing platelets, rapidly decreasing platelets, then I have to think of dengue. And I certainly can ask for whatever type of antibodies. If my laboratory would have one, I probably would have to send it by courier somewhere, and they would have to do it same day, right? So yeah, I think we have to get ready with this. We have to get ready with this in various ways, and this is very important information. NS1 immune complexes. This is what you want, right? This is what is diagnostic.
Exactly. So we have the acute phase, the viremia. Obviously, if you are able to use PCR, you have the positivity here. The platelet counts usually go really down at this phase. So once you ask for platelet count, and leukopenia is also present at this phase, very early at this phase, and the NS1 here. And then after 5 days, we have the decrease in the viremia, and we see identification of IgM and IgG. This is usually what happens in a primary infection.
Very nice. Very nice.
And this is just to show what happens in a secondary infection, Joe. So in a secondary infection, it usually is associated with very high levels of IgG. And as you see here, you also have IgM, but you have a very huge increase of IgG in a secondary infection.
Okay. Yeah, but the NS1 antibody is the one that is most relevant early on if you suspect the disease. If available, this is what you could go for. If you don't have available, treat the shock symptoms, right? It is a symptomatic treatment. There is no specific therapy, but the patient should be in intensive care unit, and you can think of dengue later if you don't have the test, right?
Yeah.
But treat the shock.
I think NS1 is very helpful to identify the presence of dengue together with leukopenia and decrease in platelet counts. We have to remind the physicians not to use salicylates and anti-inflammatory drugs because it may increase the risk of bleeding. So the secret of treating dengue is hydration. So the key message here is really to support hydration therapy for those patients with dengue, obvious symptomatic treatment. But the key message is really to be able to identify early signs, that warning signs that may represent a patient that will progress to severe dengue, and to start the treatment with hydration in those that have to be hospitalized, which fortunately is the minority. Most of the patients are treated outside the hospital, just with symptomatic treatment. We don't have so far an antiviral against dengue.
Yeah. One stupid question on this. In some intensive care unit, it used to be a standard long ago to give immunoglobulins for patients in what I call here septic shock or hemorrhagic septic shock even, right? I would expect that this may even result in more severe disease if the antibodies are not neutralizing, if you add some antibodies against the dengue virus. You, Sao Paulo, do you give IgG?
No. We have some studies that try to use some kinds of immune globulin, IV immune globulin in those patients with chalk and severe dengue, but the results are very controversial. So we don't have good experience with the use of immune globulin. Corticosteroids also have been used in some trials to see if they play a role, but also results not adequate. So these are strategies and initiatives that did not prove to be efficacious in the treatment of dengue.
Great. Thank you very much. And I guess with this, we come close to an end of your presentation. Thank you so much for all the information. And I see you have some key points.
Yeah, just key messages regarding what we discussed. This is a very common and rapidly spreading arboviral disease. This is caused by any of the 1, 2, 3, and 4 serotypes. We are seeing a continual geographic expansion, also increasing the risk of dengue among travelers. The possibility of this antibody-dependent enhancement condition worsening the prognosis of the disease is usually associated with the secondary infection. The diagnostic tests with higher sensitivity and specificity are